Welcome to This Week in Surgery, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Surgery has you covered. Our podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the surgical field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Surgery, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine, including in the operating room. This week in surgery, we will be discussing recently published articles. First, Annals of Surgery. Negotiated rates for surgical cancer care in the era of price transparency. Prices reflect market competition. Objective: to measure commercial price variation for cancer surgery within and across hospitals. Background: surgical care for solid organ tumors is costly, and negotiated commercial rates have been hidden from public view. The Hospital Price Transparency Rule, enacted in 2021, requires all hospitals to list their negotiated rates on their website, thus opening the door for an examination of pricing for cancer surgery. Methods: this was a cross-sectional study using 2021 negotiated price data disclosed by U.S. hospitals for the 10 most common cancers treated with surgery. Price variation was measured using within-hospital and across-hospital ratios. Commercial rates relative to cancer center designation and the Herfindahl-Hirschman index at the facility level were evaluated with mixed effects linear regression with random intercepts per procedural code. Results: in all, 495,200 unique commercial rates from 2,232 hospitals resulted for the 10 most common solid organ tumor cancers. Gynecologic cancer operations had the highest median rates at $6035.8/operation compared with bladder cancer surgery at $3431.0/operation. Compared with competitive markets, moderately and highly concentrated markets were associated with significantly higher rates. HHI 1501, 2500, coefficient $513.60, 95% C, $295.50, $731.70, HHI greater than 2500, coefficient $1115.50, 95% C, $913.70, $1317.20. National Cancer Institute designation was associated with higher rates, coefficient $3,451.90, 95% C, $2,853.20, $4,050.70. Conclusions: commercial payer negotiated prices for the surgical management of 10 common, solid tumor malignancies varied widely both within and across hospitals. Higher rates were observed in less competitive markets. Future efforts should facilitate price competition and limit health market concentration. Evolution in laparoscopic gastrectomy from a randomized controlled trial through national clinical practice. Objective: to examine the influence of the Logica RCT, randomized controlled trial, upon the practice and outcomes of laparoscopic gastrectomy within the Netherlands. Background: following RCTs, the dissemination of complex interventions has been poorly studied. The Logica RCT included 10 Dutch centers and compared laparoscopic to open gastrectomy. Methods: data were obtained from the Dutch Upper Gastrointestinal Cancer Audit, DUCA, on all gastrectomies performed in the Netherlands, 2012 to 2021, and the Logica RCT from 2015 to 2018. Multi-level multivariable logistic regression analyses were performed to assess the effect of laparoscopic versus open gastrectomy upon clinical outcomes before, during, and after the Logica RCT. Results: 211 patients from the Logica RCT, 105 open versus 106 laparoscopic, and 4,131 patients from the DUCA dataset, 1884 open versus 2,247 laparoscopic, were included. In 2012, laparoscopic gastrectomy was performed in 6% of patients, increasing to 82% in 2021. No significant effect of laparoscopic gastrectomy on postoperative clinical outcomes was observed within the Logica RCT. Nationally within DUCA, A shift toward a beneficial effect of laparoscopic gastrectomy upon complications was observed, reaching a significant reduction in overall adjusted odds ratio, AOR, 0.62, 95% C, 0.46 to 0.82, severe, AOR, 0.64, 95% C, 0.46 to 0.90, and cardiac complications, AOR, 0.51, 95% C, 0.30 to 0.89, after the Logica trial. Conclusions. The wider benefits of the Logica trial included the safe dissemination of laparoscopic gastrectomy across the Netherlands. The robust surgical quality assurance program in the design of the Logica RCT was crucial to facilitate the national dissemination of the technique following the trial and reducing potential patient harm during surgeons' learning curve. Social Determinants of Health Needs and Health-Related Quality of Life Among Surgical Patients, a retrospective analysis of 8,512 patients. Objective: to assess associations between social determinants of health, SDOH, needs and health-related quality of life, HERCAL, among surgical patients. Background: despite the profound impact of STO on health outcomes, studies examining the effect of STO needs on HERCAL among surgical patients are limited. Methods: a retrospective study was conducted using responses from the STO needs assessment and the patient-reported outcomes measurement information systems global health instrument of adults seen in surgical clinics at a single institution. Patient characteristics, including socioeconomic status, insurance type, education level, and employment status, were extracted. Stepwise multivariable logistic regression analyses were performed to identify independent predictors of global health scores. Results: a total of 8,512 surgical patients, mean age, 55.6 plus or minus 15.8 years, were included. 25.2% of patients reported one or more STO needs. The likelihood of reporting at least one STO need varied by patient characteristics and socioeconomic status variables. In fully adjusted regression models, food insecurity, odds ratio, or 1.53, 95% C, 1.38 to 1.70 and or 1.49, 95% C, 1.22 to 1.81, respectively, housing instability, or 1.27, 95% C, 1.12 to 1.43 and or 1.39, 95% C, 1.13 to 1.70, respectively, lack of transportation, or 1.46, 95% C, 1.27 to 1.68 and or 1.25, 95% C, 1.00 to 1.57, respectively, and unmet medication needs, or 1.31, 95% C, 1.13 to 1.52 and or 1.61, 95% C, 1.28 to 2.03, respectively, were independent predictors of poor physical and mental health. Conclusions. STO needs are independent predictors of poor patient-reported physical and mental health among surgical patients. Assessing and addressing STO needs should be prioritized in healthcare settings and by policymakers to improve HERCAL. Distal pancreatectomy. Extent of resection determines surgical risk categories. Background. Recently, subclassification of pancreatiduodenectomy in 4 differing types has been reported, because additional major vascular and multivisceral resections have been shown to be associated with an increased risk of postoperative morbidity and mortality. Objective: to classify distal pancreatectomy, DP, based on the extent of resection and technical difficulty and to evaluate postoperative outcomes with regards to this classification system. Methods: all consecutive patients who had undergone DP between 2001 and 2020 at a high-volume pancreatic surgery center were included in this study. DPs were subclassified into 4 distinct categories reflecting the extent of resection and technical difficulty, including standard DP, type 1, DP with venous, type 2, multivisceral, type 3, or arterial resection, type 4. Patient characteristics, perioperative data, and postoperative outcomes were analyzed and compared among the 4 groups. Results: A total of 2,135 patients underwent DP. Standard DP was the most frequently performed procedure, 64.8%. The overall 90-day mortality rate was 1.6%. Morbidity rates were higher in patients with additional vascular or multivisceral resections, and 90-day mortality gradually increased with the extent of resection from standard DP to DP with arterial resection, type 1, 0.7%, type 2, 1.3%, type 3, 3%, type 4, 8.7%, p less than 0.0001. Multivariable analysis confirmed the type of DP is an independent risk factor for 90-day mortality. Conclusions. Postoperative outcomes after DP depend on the extent of resection and correlate with the type of DP. The implementation of the 4-type classification system allows standardized reporting of surgical outcomes after DP, improving comparability of future studies. Study of risk factors for readmission after pancreatectomy for cancer, analysis of nationwide cohort. Objective: to identify the factors associated with readmission after pancreatectomy for cancer, and to assess their impact on the 1-year mortality in a French multicentric population. Background: pancreatectomy is a complex procedure with high morbidity that increases the length of hospital stay and jeopardizes survival. Hospital readmissions lead to increased health system costs, making this a topic of great interest. Methods: data collected from patients who underwent pancreatectomy for cancer between 2011 and 2019 were extracted from a French National Medico-Administrative database. A descriptive analysis was conducted to evaluate the association of baseline variables, including age, sex, liver-related comorbidities, Charlson Comorbidity Index, tumor localization, and use of neoadjuvant therapy, along with hospital type and volume, with readmission status. Centers were divided into low and high volumes according to the cutoff of 26 cases/year. Logistic regression models were developed to determine whether the identified bivariate associations persisted after adjusting for the patient characteristics. The mortality rates during readmission and at 1 year postoperatively were also determined. Results: of 22,935 patients who underwent pancreatectomy, 9,129, 39.3%, were readmitted within 6 months. Readmission rates by year did not vary over the study period, and mean readmissions occurred within 20 days after discharge. Multivariate analysis showed that male sex, odds ratio or equals 1.12, age greater than 70 years or equals 1.16, comorbidities or equals 1.21, distal pancreatectomy or equals 1.11, and major postoperative complications or equals 1.37, were predictors of readmission. Interestingly, readmission and surgery in low-volume centers increased the risk of death at 1 year by a factor of 2.15, 2.01 to 2.31, p less than 0.001, and 1.31, 1.17 to 1.47, p less than 0.001, respectively. Conclusions: readmission after pancreatectomy for cancer is high with an increased rate of 1-year mortality. Next article is from Journal of American Medical Association Surgery. Magnetic seed versus Guidewire breast cancer localization with magnetic lymph node detection. A randomized clinical trial. Importance: Guidewires have been the standard for breast lesion localization but pose operative and logistic challenges. Paramagnetic seeds have shown promising results, but to the author's knowledge, no randomized comparison has been performed. Objective: to determine whether the combination of a paramagnetic seed and supraparamagnetic iron oxide, SPIO, is equivalent to Guidewire SPIO for breast cancer localization and sentinel lymph node detection, SLND. Design, setting, and participants. This was a Phase 3, pragmatic, equivalence, 2-arm, open-label, randomized clinical trial conducted at 3 university and/or community hospitals in Sweden from May 2018 to May 2022. Included in the study were patients with early breast cancer planned for breast conservation and SLND. Study data were analyzed July to November 2022. Interventions: participants were randomly assigned 1-to-1 to a paramagnetic seed or a Guidewire. All patients underwent SLND with SPIO. Main outcomes and measures: re-excision rate and resection ratio, defined as actual resection volume, optimal resection volume. Results: a total of 426 women, median, IQR, age, 65, 56 to 71 years, median, IQR, tumor size, 11, 8 to 15, were included in the study. The re-excision rate was 2.90%, 95% C, 1.60% to 4.80%, and the median, IQR, resection ratio was 1.96, 1.15 to 3.44. No differences were found between the Guidewire and the seed in re-excisions, 6 of 211, 2.84%, versus 6 of 209, 2.87%, difference, minus 0.03%, 95% C, minus 3.20% to 3.20%, p equals 0.99, or resection ratio, median, 1.93, IQR, 1.18 to 3.43 versus median, 2.01, IQR, 1.11 to 3.47, p equals 0.70. Overall SLN detection was 98.6%, 95% C, 97.1% to 99.4%, with no differences between arms, 203 of 207, 98.1%, versus 204 of 206, 99.0%, difference, minus 0.9%, 95% C, minus 3.6% to 1.8%, p equals 0.72. More failed localizations occurred with the Guidewire, 21 of 208, 10.1%, versus 4 of 215, 1.9%, difference, 8.2%, 95% C, 3.3% to 13.2%, p less than 0.001. Median, IQR, time to specimen excision was shorter for the seed, 15, 10 to 22 minutes versus 18, 12 to 30 minutes, p equals 0.01, as was the total operative time, 69, 56 to 86 minutes versus 75.5, 59 to 101 minutes, p equals 0.03. The experience of surgeons, radiologists, and surgical coordinators was better with the seed. Conclusions and relevance: the combination of SPIO and a paramagnetic seed performed comparably with SPIO and Guidewire for breast cancer conserving surgery and resulted in more successful localizations, shorter operative times, and better experience. Clinical outcomes after traumatic brain injury and exposure to extracranial surgery. ATTRACT TBI study. Importance: traumatic brain injury, TBI, is associated with persistent functional and cognitive deficits, which may be susceptible to secondary insults. The implications of exposure to surgery and anesthesia after TBI warrant investigation, given that surgery has been associated with neurocognitive disorders. Objective: to examine whether exposure to extracranial, EC, surgery and anesthesia is related to worse functional and cognitive outcomes after TBI. Design, setting, and participants: this study was a retrospective, secondary analysis of data from the Transforming Research and Clinical Knowledge in Traumatic Brain Injury, TRACK TBI, study, a prospective cohort study that assessed longitudinal outcomes of participants enrolled at 18 level I U.S. trauma centers between February 1, 2014, and August 31, 2018. Participants were 17 years or older, presented within 24 hours of trauma, were admitted to an inpatient unit from the emergency department, had known Glasgow Coma Scale, GCS, and had computed tomography, CT, status, and did not undergo cranial surgery. This analysis was conducted between January 2, 2020, and August 8, 2023. Exposure: participants who underwent EC surgery during the index admission were compared with participants with no surgery in groups with a peripheral orthopedic injury or a TBI and were classified as having uncomplicated mild TBI, GCS score of 13 to 15 and negative CT results, CT-MTBI, complicated mild TBI, GCS score of 13 to 15 and positive CT results, CT plus MTBI, or moderate to severe TBI, GCS score of 3 to 12, M/SB. Main outcomes and measures: the primary outcomes were functional limitations quantified by the Glasgow Outcome Scale extended for all injuries, GOSA all, and brain injury, GOSA TBI, and neurocognitive outcomes at 2 weeks and 6 months after injury. Results: a total of 1835 participants, mean SD, age 42.2, 17.8 years, 1,279, 70% male, 299 black, 1,412 white, and 96 other were analyzed, including 1,349 non-surgical participants and 486 participants undergoing EC surgery. Conclusions and relevance: this study found that exposure to EC surgery and anesthesia was associated with adverse functional outcomes and impaired executive function after TBI. This unfavorable association warrants further investigation of the potential mechanisms and clinical implications that could inform decisions regarding the timing of surgical interventions in patients after TBI. Next, we will be discussing articles from British Journal of Surgery. Surgical stress response in robot-assisted versus laparoscopic surgery for colon cancer, SURIRALS, randomized clinical trial. Background: evidence for the routine use of robotic technology and its impact on short-term outcomes in colon cancer surgery is lacking. The aim of this study was to compare the surgically induced systemic stress response and clinical and patient-reported outcomes for patients undergoing robot-assisted or laparoscopic colon cancer surgery. Methods: in this double-blinded superiority RCT completed between August 2021 and March 2023, patients with stage 1 to 3 colon cancer were randomized in a 1:1 ratio to undergo either robot-assisted or laparoscopic colon cancer surgery. The primary outcome was changes in the systemic stress response, characterized by C-reactive protein expression in the first 3 postoperative days. Secondary outcomes were intraoperative and postoperative complications and patient-reported outcomes. The latter included quality of recovery 15 and pain intensity using a visual analog scale. Results: in total, 128 patients were screened for potential inclusion in this study, 50 patients, 25 in the robot-assisted group and 25 in the laparoscopic group, were included in the final follow-up and analysis. The postoperative C-reactive protein response was higher on the first postoperative day in the laparoscopic group, mean difference equals 19.88 mg/L, 95% CI 3.89 to 35.86, p equals 0.045. No statistically significant differences were noted for C-reactive protein expression on the second and third postoperative days. Conclusion: adopting robot-assisted surgery for stage 1 to 3 colon cancer is associated with a reduction in the surgical stress response. Next we will be discussing articles from Journal of Vascular Surgery. Preoperative predictors of non-home discharge after fenestrated branched endovascular repair of complex abdominal and thoracoabdominal aortic aneurysms. Background: non-home discharge, NHD, has significant implications for patient counseling and discharge planning and is frequently required following fenestrated branched endovascular aortic repair, FBFR, of complex abdominal aortic aneurysms, CAAA, and thoracoabdominal aortic aneurysms, TAAA. We aim to identify preoperative predictors of NHD after elective FBFR for CA and TA and develop a risk calculator able to predict NHD. Methods: a retrospective review of prospectively collected data on all patients undergoing FBFR between January 2007 and December 2021 at a single institution was performed. Exclusion criteria were admission from a non-home setting, emergency and repeat FBFR, and discharge to an unknown destination. The cohort was randomly split into separate development, 70% of patients, and validation, 30%, cohorts to develop a predictive calculator for NHD. Independent variables associated with NHD were assessed in a series of logistic regression analyses from 100 bootstrap samples of the development set, and a model was developed using the most predictive variables. Resulting parameter estimates were applied to data in the validation set to assess model discrimination and calibration. Results: from the initial cohort of 712 FBFR patients, 644 were included in the study, 74% male, mean age, 75.4 plus or minus 7.6 years, including 452 with CA, 70%, and 192 with TA, 30%. Early mortality occurred in 8 patients, 1.2%, 5 in CA and 3 in TA, and the median hospital stay was 5 days, 4 for CA and 7 for TA. 97 patients, 15%, had a NHD. On multivariable analysis, older age, per year, odds ratio, or 1.08, p less than 0.001, female gender, or 3.03, p less than 0.001, smoking, or 2.86, p equals 0.01, congestive heart failure, or 3.05, p equals 0.004, peripheral artery disease, or 1.81, p equals 0.07, and extend I, or 3.17, 2, or 2.84, and 3, or 2.52, all p equals 0.08, TAs were associated with an increased likelihood of NHD in the development set. Based on these factors, the risk calculator was developed, which accurately predicts NHD in the validation set with an area under the curve of 0.7. Conclusions: older, female smokers with congestive heart failure and peripheral artery disease and more extensive aneurysms are at highest risk of NHD after FB-EVAR. Using only preoperative factors, our risk calculator can predict accurately who will have a NHD, allowing enhanced preoperative patient counseling and accelerated hospital discharge. Reducing aneurysm sac growth and secondary interventions following endovascular abdominal aortic aneurysm repair by preemptive coil embolization of the inferior mesenteric artery and lumbar arteries. Objective: Type 2 endoleak, EL2, is the most common complication following endovascular aneurysm repair, EVAR, leading to continued sac growth and potential rupture. In this study, we examined the association between patency of the inferior mesenteric artery, IMA, and lumbar arteries, LAs, with respect to sac growth. The effect of preemptive embolization of the IMA and/or LAs on the need for secondary interventions for sac growth post-EVAR was also evaluated. Methods: a retrospective cohort study was performed on consecutive patients who underwent EVAR for non-ruptured, infrarenal abdominal aortic aneurysms, AAAs, from January 2012 to December 2020. A select group of patients underwent preemptive embolization of the IMA and/or LA. Patients with any types I, 3, or 4 endoleaks were excluded. Patency of the IMA and LA on preoperative computed tomography angiogram, CTA, was evaluated on Terra Recon workstation. All secondary interventions to treat EL2 were recorded. Sac growth was defined as centerline axial diameter increase of greater than or equal to 5 mm on follow-up CTA. Results: a total of 300 patients, mean age, 74 plus or minus 8.5 years, 83.7% male, underwent EVAR. 99 patients had preemptive embolization of the IMA and/or LA. Mean follow-up of the cohort was 59.3 plus or minus 30.5 months. 36 patients, 12%, demonstrated sac growth on follow-up. 12 of these, 33.3%, had preemptive embolization. The median time until detection of sac growth was 28.8 months, interquartile range, 15.2 to 46.5 months, with a mean growth of 10.1 plus or minus 6.4 millimeters. Sac growth was significantly associated with presence of EL2, 27 of 36, 75%, with EL2 versus 9 of 36, 25%, without EL2, p less than 0.001. Patients with sac growth had a higher mean total number, 2.6 plus or minus 1.5, of patent lower LAs, L3, L4, compared with those without, 2.0 plus or minus 1.4, p equals 0.03. Patency of L1, L2, and L3 LAs were not associated with sac growth. However, patency of at least one L4 LA was significantly associated with sac growth, 14.8% versus 7.7%, p equals 0.04. The highest incidence of sac growth, 17.6%, was seen when both IMA and L4 LA were patent, significantly different from the lowest incidence, 5.3%, when both were occluded preoperatively, p equals 0.018. Preemptive coiling of the IMA and/or LA significantly reduced the need for post-EVAR secondary intervention for sac growth. Freedom from post-EVAR secondary intervention was achieved in 92 of 99, 92.9%, pre-EVAR coiled patients versus 163 of 201, 81.5%, patients who did not undergo pre-EVAR coiling, p equals 0.009. Conclusions. Preemptive coil embolization of the IMA and LAs, especially L4-LA, reduces the need for secondary interventions for sac growth, potentially improving the long-term durability of EVAR. Modified Harborview risk score improves ease in predicting mortality after ruptured abdominal aortic aneurysm repair. Objective. The Harborview risk score, HRS, is a simple, accurate 4-point preoperative risk scoring system used to predict 30-day mortality following ruptured abdominal aortic aneurysm, RA, repair. The hours assigns 1 point for each of the following: age greater than 76 years, pH less than 7.2, creatinine greater than 2 mg/dl, and any episode of severe hypotension, systolic blood pressure less than 70 mm of mercury. One potential limitation of this risk scoring system is that arterial blood gas, ABG, analysis is required to determine arterial pH. Because ABG analysis is not routinely performed prior to patient transfer or RA repair, we sought to determine if the hours could be modified by replacing pH with the International Normalized Ratio, INR, a factor that has been previously shown to have a strong and independent association with 30-day death after RA repair. Methods. A retrospective review of all RA repairs done at a single academic medical center between January 2002 and December 2018 was performed. Our traditional hours was compared with a modified score, in which pH less than 7.2 was replaced with INR greater than 1.8. Patients were included if they underwent RA repair, open or endovascular, and if they had preoperative laboratory values available to calculate both the traditional and modified hours. Results. During the 17-year study period, 360 of 391 repairs met inclusion criteria. Observed 30-day mortality using the modified scoring system was 17%, 18,106, for a score of 0 points, 43%, 53,122, for 1 point, 54%, 52,96, for 2 points, 84%, 27/30 seconds, for 3 points, and 100%, 4/4, for 4 points. Receiver operating characteristic analysis revealed similar ability of the two scoring systems to predict 30-day death. There was no significant difference in the area under the curve, AUC, comparing the traditional, AUC equals 0.74, and modified, AUC equals 0.72, hours, p equals 0.3. Conclusions. Although previously validated among a modern cohort of patients with RA, our traditional 4-point risk score is limited in real-world use by the need for an ABG. Substituting INR for pH improves the usefulness of our risk scoring system without compromising accuracy in predicting 30-day mortality after RA. Using machine learning to predict outcomes following suprainguinal bypass. Objective. Suprainguinal bypass for peripheral artery disease, PAD, carries important surgical risks, however, outcome prediction tools remain limited. We develop machine learning, ML, algorithms that predict outcomes following suprainguinal bypass. Methods. The Vascular Quality Initiative database was used to identify patients who underwent suprainguinal bypass for PAD between 2003 and 2023. We identified 100 potential predictor variables from the index hospitalization, 68 preoperative, demographic/clinical, 13 intraoperative, procedural, and 19 postoperative, in-hospital course/complications. The primary outcomes were major adverse limb events, male, composite of untreated loss of patency, thrombectomy/thrombolysis, surgical revision, or major amputation, or death at 1 year following suprainguinal bypass. Our data were split into training, 70%, and test, 30%, sets. Using tenfold cross-validation, we trained 6 ML models using preoperative features, extreme gradient boosting, XGBoost, random forest, naive Bayes classifier, support vector machine, artificial neural network, and logistic regression. The primary model evaluation metric was area under the receiver operating characteristic curve, ORAC. The best performing algorithm was further trained using intra and postoperative data. Model robustness was evaluated using calibration plots and Breyer scores. Performance was assessed on subgroups based on age, sex, race, ethnicity, rurality, median area deprivation index, symptom status, procedure type, prior intervention for PAD, concurrent interventions, and urgency. Results. Overall, 16,832 patients underwent suprainguinal bypass, and 3,136, 18.6%, developed 1-year male or death. Patients with 1-year male or death were older, mean age, 64.9 versus 63.5 years, p less than 0.001, with more comorbidities, had poorer functional status, 65.7% versus 80.9% independent baseline, p less than 0.001, and were more likely to have chronic limb-threatening ischemia, 67.4% versus 47.6%, p less than 0.001, than those without an outcome. Despite being at higher cardiovascular risk, they were less likely to receive acetylsalicylic acid or statins preoperatively and at discharge. Our best performing prediction model at the preoperative stage was XGBoost, achieving an ORAC of 0.92, 95% confidence interval, c. 0.91 to 0.93. In comparison, logistic regression had an ORAC of 0.67, 95% c. 0.65 to 0.69. Our XGBoost model maintained excellent performance at the intra and postoperative stages, with ORACs of 0.93, 95% c. 0.92 to 0.94, and 0.98, 95% c. 0.97 to 0.99, respectively. Conclusions. We developed ML models that accurately predict outcomes following suprainguinal bypass, performing better than logistic regression. Our algorithms have potential for important utility in guiding perioperative risk mitigation strategies to prevent adverse outcomes following suprainguinal bypass. Next article is from Surgical Endoscopy. Conversion of one anastomosis gastric bypass, OAGB, to Roux-en-Y gastric bypass, RYGB, for gastroesophageal reflux disease, GERD, who is more at risk. A multi-center study. Background. Although gastroesophageal reflux disease, GERD, affects 0.6% to 10% of patients operated on for one anastomosis gastric bypass, OAGB, only about 1% require surgery to convert to Roux-en-Y gastric bypass, RYGB 3,4,5. The aim of the present study was to analyze the characteristics of OGB patients converted to RYGB for GERD not responding to medical treatment. Methods. This retrospective multicenter study included patients who underwent conversion from OGB to RYGB for severe GERD. The conversion was performed with resection of the previous gastrojejunal anastomosis and the use of the afferent loop as a new biliary loop. Results. A total of 126 patients were included in the study. Of these patients, 66, 52.6%, had a past medical history of bariatric restrictive surgery, gastric banding, sleeve gastrectomy. A hiatal hernia, HH, was present in 56 patients, 44.7%. The association between previous restrictive surgery and HH was recorded in 33, 26.2%, patients. Three-dimensional gastric computed tomography showed an average gastric pouch volume of 242.4 plus or minus 55.1 cubic centimeters. Conversion to RYGB was performed on average 60 plus or minus 35.6 months after OGB. 7 patients, 5.5%, experienced an early postoperative complication, 4 patients grade 5 and 3 grade IIB, and 3, 2.4%, a late complication. Patients showed further weight loss after RYGB conversion and an average of 24.8 plus or minus 21.7 months after surgery, with a mean percent of total weight loss, percent TWL, of 6.9 plus or minus 13.6 kilograms. From a clinical point of view, the problem of GERD was definitively solved in more than 90% of patients. Conclusions. Situations that weaken the esogastric junction appear to be highly frequent in patients operated on for OGB and converted to RIGB for severe reflux. Similarly, the correct creation of the gastric pouch could play an important role in reducing the risk of conversion to RIGB for GERD. Evolution of laparoscopic liver resection in the last 2 decades, lessons from 2,000 cases at a referral Korean center. Background and aims. Laparoscopic liver resection, LLR, has evolved to become the standard surgical approach in many referral centers worldwide. The aim of this study was to analyze how LLR evolved at a single high-volume referral center since its introduction, more than 2 decades ago. Methods. Data from all consecutive LLR between January 2003 and September 2022 at the Seoul National University Bundong Hospital were analyzed. Perioperative outcomes were compared between 3 time periods, with major technological innovations considered as landmarks, before introduction of laparoscopic US and CUSA, 2003 to 2006, before, 2006 to 2015, and after, 2015 to 2022, introduction of high-definition scope. Results. During the analyzed time periods, the number of technically challenging procedures increased from 39.2 to 61.1%, p less than 0.001. The most recent period showed shorter median operation time, from 267.5 to 175, p less than 0.001, lower median estimated blood loss, EBL, from 500 to 300 milliliters, p less than 0.001, lower intraoperative transfusions, from 33.8 to 9.3%, p less than 0.001, shorter median postoperative hospital stay, from 12 to 6 days, p less than 0.001. The time period, a technical major resection and an underlying liver cirrhosis were found to be the associated with longer operation time, p less than 0.001, in the multivariable linear regression analysis, while tumor size, technically major surgeries and liver cirrhosis were associated with higher EBL, p less than 0.001. Conclusion. During the last 2 decades, the indications for patients undergoing LLR have expanded significantly, including more and more challenging procedures and frail patients. Despite such challenges, perioperative outcomes improved, although technically major procedures, cirrhotic patients and huge tumors have still to be considered challenging situations. Next article is from Annals of Surgical Oncology. Breast cancer incidence among Asian American women in New York City, disparities in screening and presentation. Background. Asian American, as AM, women have some of the lowest rates of up-to-date breast cancer screening, and lack of disaggregated racial/ethnic data can mask disparities. We evaluated presentation patterns among us AMs at 2 hospitals with distinct communities, New York Presbyterian Queens, NYPQ, in Flushing, Queens, and Weill Cornell Medical Center, WCM, on the Upper East Side, UES, neighborhood of Manhattan. Patients and methods. Patients with newly diagnosed breast cancer between January 2019 and December 2022 were identified using a prospective database and clinical data collected. Patients were categorized as self-reported Asian versus non-Asian. The Asian group was disaggregated as Chinese Asian versus other Asian. Physician workforce data were obtained from public records. Results. A total of 3,546 patients, 1,162 NIP, 2,384 WCM, were included. More NIP patients identified as Asian compared with WCM, 49 versus 14%, p less than 0.001. Asian patients were mostly East Asian Chinese, NIP 61%, WCM 53%. More Chinese patients at NIP reported Chinese as their preferred language, 81 versus 33%, p less than 0.001. Greatest differences of screen-detected disease frequency were seen between NIP and WCM Chinese patients, 75 versus 59%, p less than 0.001. 80% of NIP Chinese patients presented with stage 0/I disease versus 69% at WCM, p equals 0.007, a difference not observed between other Asian patients, 75% NIP, 68% WCM, p equals 0.095. 3% of used physicians versus 16% in Flushing reported speaking Chinese. Conclusions: Chinese patients residing in a neighborhood with more Chinese-speaking physicians more frequently presented with screen-detected, early-stage breast cancer. Stage distribution differences were not apparent among the aggregated pool of other Asian patients, suggesting cancer disparities may be masked when ethnic groups are studied in aggregate. Next article is from Obesity Surgery. Patients' preference for same-day discharge or hospitalization after bariatric surgery. Purpose: enhanced recovery after bariatric surgery protocols have proven to be effective in reducing complication rates and length of stay. Guidelines do not include a recommendation on the length of hospital stay, whereas same-day discharge is currently widely investigated on safety and feasibility. However, none of these studies takes patient preferences into account. The study aimed to reveal the patient's preference for outpatient surgery, OS, in patients who underwent primary bariatric surgery. Materials and methods. A single-center preference-based randomized trial was performed between March and December of 2021. Adult patients planned for primary bariatric surgery were able to choose their care pathway, either OS with remote heart and respiratory rate monitoring by a wearable data logger or standard care with at least one night hospitalization. Results: out of the 202 patients, nearly everyone, 98.5%, had a preference. Of 199 patients, 49.7%, chose inpatient surgery. Of the 100 with a preference for OS, 23 stayed in the hospital due to medical reasons and 12 patients changed their preference. Based on both initial preference and changed preference, there were no differences between sex, age, body mass index, and comorbidities such as diabetes mellitus, hypertension, and atrial fibrillation, nor in the use of anticoagulants or type of surgery. Conclusion: patients seem to have a strong preference for their stay after a bariatric procedure. The preference is equally divided between outpatient and inpatient surgery and is not influenced by any patient characteristics. Clinical management of major postoperative bleeding after bariatric surgery. Introduction. Major postoperative bleeding (POB) is the most common complication after bariatric surgery. Its intensity varies from self-limiting to life-threatening situations. Comprehensive decision-making and treatment strategies are mandatory but not established yet. Methods. We retrospectively analyzed our prospectively collected database of our bariatric patients during 2012 to 2022. The primary study endpoint was major postoperative bleeding, POB, defined as hemoglobin drop greater than 2 grams/dl or clinically relevant bleeding requiring intervention, transfusion, endoscopy or surgery. Secondary endpoints were overall complications according to Clavin-Dindo classification and Comprehensive Complication Index, CCI. Results. We identified 1,017 patients, of whom 667 underwent gastric bypass, GB, and 350 sleeve gastrectomy, SG. Major postoperative bleeding occurred in 39 patients, total 3.8%, 5.1% after GB and 2.3% after SG. Patients with MPOB were more often diagnosed with type 2 diabetes, p equals 0.039, chronic kidney failure, p equals 0.013, or received antiplatelet drug treatment, p equals 0.003. The interval from detection to intervention within 24 hours was 92.1%, 35-39. Blood transfusions were necessary in 2039 cases, total 51.3%, 45.2% after GB and 75% after SG, p equals 0.046. Luminal bleeding only occurred after GB, 1931, 61.3%, while all MPOB after SG were intra-abdominal, p equals 0.002. Reoperations were performed in 2139, total 53.8%, 48.4% after GB and 75% after SG, p equals 0.067. CCI in patients with MPOB was 34.7 overall, with 31.2 after GB and 47.9 after SG, p equals 0.005. Conclusion. The clinical appearance of MPOB depends on the type of surgery with severe bleedings after SG. We suggest a surgery first approach for MPOB after SG and an endoscopy first approach after GB. Metabolic and bariatric surgery in patients with obesity class V, BMI greater than 60 kg/m2, a modified Delphi study. Background. Metabolic and bariatric surgery, MBS, is the preferred method to achieve significant weight loss in patients with obesity class V, BMI greater than 60 kg/m2. However, there is no consensus regarding the best procedures for this population. Additionally, these patients will likely have a higher risk of complications and mortality. The aim of this study was to achieve a consensus among a global panel of expert bariatric surgeons using a modified Delphi methodology. Methods. A total of 36 recognized opinion makers and highly experienced metabolic and bariatric surgeons participated in the present Delphi consensus. 81 statements on preoperative management, selection of the procedure, perioperative management, weight loss parameters, follow-up, and metabolic outcomes were voted on in 2 rounds. A consensus was considered reached when an agreement of greater than or equal to 70% of experts' votes was achieved. Results. A total of 54 out of 81 statements reached consensus. Remarkably, more than 90% of the experts agreed that patients should be notified of the greater risk of complications, the possibility of modifications to the surgical procedure, and the early start of chemical thromboprophylaxis. Regarding the choice of the procedure, SOTI-S, RIGB, and OGB were the top 3 preferred operations. However, no consensus was reached on the limb length in these operations. Conclusion. This study represents the first attempt to reach consensus on the choice of procedures as well as perioperative management in patients with obesity class V. Although overall consensus was reached in different areas, more research is needed to better serve this high-risk population. Next article is from International Journal of Surgery. Comparing the impact of three-dimensional digital visualization technology versus traditional microscopy on microsurgeons in microsurgery, a prospective self-controlled study. Background. Emerging three-dimensional digital visualization technology, DVT, provides more advantages than traditional microscopy in microsurgery. However, its impact on microsurgeons' visual and nervous systems and delicate microsurgery is still unclear, which hinders the wider implementation of DVT in digital visualization for microsurgery. Methods and material. 42 microsurgeons from the Zhongshan Ophthalmic Center were enrolled in this prospective self-controlled study. Each microsurgeon consecutively performed 30 minutes conjunctival sutures using a three-dimensional digital display and a microscope, respectively. Visual function, autonomic nerve activity, and subjective symptoms were evaluated before and immediately after the operation. Visual functions, including accommodative lag, accommodative amplitude, near point of convergence and contrast sensitivity function, CSF, were measured by an expert optometrist. Heart rate variability was recorded by a wearable device for monitoring autonomic nervous activity. Subjective symptoms were evaluated by questionnaires. Microsurgical performance was assessed by the Video-Based Objective Structured Assessment of Technical Skill, OSATS, tool. Results. Accommodative lag decreased from 0.63, 0.18, diopters, D, to 0.55, 0.16, D, P equals 0.014. Area under the log contrast sensitivity function increased from 1.49, 0.15, to 1.52, 0.14, P equals 0.037, and heart rate variability decreased from 36.00, 13.54, milliseconds, ms, to 32.26, 12.35, ms, P equals 0.004, after using the DVT, but the changes showed no differences compared to traditional microscopy, P greater than 0.05. No statistical significance was observed for global OSAT scores between the 2 rounds of operations, mean difference, 0.05, 95% C, minus 1.17 to 1.08, points, P equals 0.95. Subjective symptoms were quite mild after using both techniques. Conclusions. The impact of DVT-based procedures on microsurgeons includes enhanced accommodation and sympathetic activity, but the changes in surgical performance are not significantly different from those of microscopy-based microsurgery. Our findings indicate that short-term use of DVT is reliable for microsurgery, and the long-term effect of using DVT deserve more consideration. Next article is from Journal of the American College of Surgeons. Balloon rises above, REBOA at zone 1st of may be superior to resuscitative thoracotomy. Background: the use of zone 1 REBOA for life-threatening trauma has increased dramatically. Study design: the aortic occlusion for resuscitation in trauma and acute care surgery database was queried for blunt and penetrating trauma between 2013 and 2021. Outcomes were examined both for mechanisms of injury combined and separately and for combinations of abdominal injury with and without traumatic brain injury and chest injuries, abbreviated injury scale, AIS, score greater than 2. Results: a total of 531 patients underwent REBOA, 408 with blunt injury and 123 with penetrating injury, and 1,603, 595 with blunt injury and 1,008 with penetrating injury, underwent resuscitative thoracotomy, RT. Mean age was 38.5 plus or minus 16 years and mean injury severity score was 34.5 plus or minus 21, 57.7% had chest AIS score of more than 2, 21.8% had head AIS score of more than 2, and 37.3% had abdominal AIS score of more than 2. Admission Glasgow Coma Scale was 4.9 plus 4, and systolic blood pressure aortic occlusion, A.I.O, was 22 plus 40 mm of mercury. No differences in outcomes in REBOA or RT patients were identified between institutions, p greater than 0.5. After inverse probability weighting, Glasgow Coma Scale, age, injury severity score, systolic blood pressure at A.I.O, CPR A.I.O, and blood product transfusion, REBOA was superior to RT in both blunt, odds ratio, or 4.7, 95% C 1.9 to 11.7, and penetrating, or 4.9, 95% C 1.7 to 14, injuries, across all spectrums of injury, p less than 0.01. Overall mortality was significantly higher for A.I.O more than 90 minutes compared with less than 30 minutes in blunt, or 4.6, 95% C 1.5 to 15, and penetrating, or 5.4, 95% C 1.1 to 25, injuries. Duration of A.I.O more than 60 minutes was significantly associated with mortality after penetrating abdominal injury, or 5.1, 95% C 1.1 to 22, and abdomen and head, or 5.3, 95% C 1.6 to 18. Conclusions: in-hospital survival is higher for patients undergoing REBOA than RT for all injury patterns. Complete A.I.O by REBOA or RT should be limited to less than 30 minutes. Neither hospital and procedure volume nor trauma verification level impacts outcomes for REBOA or RT. Axillary nodal response to neoadjuvant TDM1 combined with pertuzumab in a prospective Phase 2 multi-institution clinical trial. Background: patients with ERBB2, HER2-positive breast cancer experience high pathologic complete response, PCR, rates after standard neoadjuvant anti-HER2 systemic therapy. We examined axillary pathologic nodal response to neoadjuvant dual HER2-targeted therapy alone, based on breast pathologic response, in a multi-institution clinical trial. Study design: patients with HER2-positive breast cancer were enrolled to a Phase 2 single-arm trial, which administered 6 cycles of neoadjuvant trastuzumab emtansine, TDM1, plus pertuzumab. Rates of pathologic nodal disease, IPN, in patients who were clinically node-negative, CN0, and node-positive, CN1, were analyzed, by residual breast disease, PCR and residual cancer burden, RCB, I/3. Results: 158 patients completed preoperative treatment and proceeded to surgery. Of 92 patients who were CN0, 48, 52.2%, and 10, 10.9%, experienced breast PCR and RCBI, respectively. Of these, 100% were IPN0. Of 34 with RCB 2 to 3, 26, 76.5%, were IPN0. Of 30 patients who were CN1 with breast PCR, 100% were IPN0. Of the 12 patients who were CN1 with RCBI, 66.7% were IPN0. And of the 24 patients who were CN1 with RCB2-3, 25% were IPN0. IPN0 rates were significantly different between patients who did and did not experience a PCR, in both CN0, p equals 0.002, and CN1, p less than 0.001 subgroups. Conclusions. Patients with HER2-positive breast cancer treated with dual HER2-targeted therapy who experienced a breast PCR or RCBI response were frequently IPN0. These findings support future trials considering omission of axillary surgical staging for patients with HER2-positive breast cancer and neoadjuvant trials of active HER2-targeted regimens, particularly if they experience breast PCR or RCBI. Next article is from Journal of Trauma and Acute Care Surgery. Eliminating the benzos, a benzodiazepine-sparing approach to preventing and treating alcohol withdrawal syndrome. Background. Alcohol withdrawal syndrome, AWS, represents significant cost to the hospitalized trauma population from a clinical and financial perspective. Historically, AWS has been managed with benzodiazepines. Despite their efficacy, benzodiazepines carry a heavy adverse effect profile. Recently, benzodiazepine-sparing protocols for the prophylaxis and treatment of AWS have been used in medical patient populations. Most existing benzodiazepine-sparing protocols use phenobarbital, while ours primarily uses gabapentin and clonidine, and no such protocol has been developed and examined for safety and efficacy specifically within a trauma population. Methods. In December of 2019, we implemented our benzodiazepine-sparing protocol for trauma patients identified at risk for alcohol withdrawal on admission. Trauma patients at risk for AWS admitted to an academic Level 1 trauma center before, conventional, and after, benzodiazepine-sparing, BS, protocol implementation were compared. Outcomes examined include morphine milligram equivalent dosing rates and lorazepam equivalent dosing rates, as well as the Clinical Institute Withdrawal Assessment for Alcohol Revised, CIWR, scores, hospital length of stay, intensive care unit length of stay, and ventilator days. Results. A total of 387 conventional and 134 benzodiazepine-sparing patients were compared. Injury severity score, 13 versus 16, p equals 0.10, and admission alcohol levels, 99 versus 149, p equals 0.06, were similar. Patients in the BS pathway had a lower maximum daily CIWR, 2.7 versus 1.5, p equals 0.04. While mean morphine milligram equivalent per day was not different between groups, 31.5 versus 33.6, p equals 0.49, mean lorazepam equivalents per day was significantly lower in the BS group, 1.1 versus 0.2, p less than 0.01. Length of stay and vent days were not different between the groups. Conclusion. Implementation of a benzodiazepine-sparing pathway that uses primarily clonidine and gabapentin to prevent and treat alcohol withdrawal syndrome in trauma patients is safe, reduces the daily maximum CIWR, and significantly decreases the need for benzodiazepines. Future studies will focus on outcomes affected by avoiding AWS and benzodiazepines in the trauma population. Next article is from the American Journal of Surgery. Single-center outcomes from parenchymal-sparing resections and microwave ablations for neuroendocrine tumor liver metastases. Background. Reported outcomes after surgical debulking in patients with advanced neuroendocrine tumor liver metastases, NETM, are sparse. Methods. NETM patients that underwent surgical debulking from 2019 to 2021 were reviewed. Trends in perioperative liver function, complications, symptom response, and progression-free survival were examined. Results. 1,069 liver lesions were debulked from 53 patients using a combination of parenchymal-sparing resections, PSR, and ultrasound-guided microwave ablations, MWA. Postoperative transaminitis and thrombocytopenia were common, and severity correlated with increasing number of lesions. Laboratory markers for synthetic liver function did not differ according to the number of lesions debulked. 13% of patients sustained a Clavin-Dindo grade 3 or 4 complication which was not associated with the number of lesions targeted. All patients with preoperative symptoms had improvement after surgery. Median time to progression was 10.9 months. Conclusions. PSR with MWA for large numbers of NETLM is safe and effective for symptom control and does not affect synthetic liver function. Evaluating the impact of lifting mandatory smoking cessation prior to elective abdominal wall reconstruction. A single-center experience. Introduction. Many studies identify active smoking as a significant risk factor for postoperative wound and mesh complications in patients undergoing abdominal wall reconstruction surgery. However, our group conducted an analysis using data from the A.I.O database, which revealed similar rates of surgical site infection, SSI, and surgical site occurrence requiring procedural intervention, SIP, between active smokers and non-smokers. As a result, the C.L. Evelyn Clinic Center for Abdominal Core Health instituted a policy change where active smokers were no longer subject to surgical delay. Our study aims to evaluate the impact of active smoking on the outcomes of these patients. Methods. We identified active smoking patients who had undergone open, elective, clean ventral hernia repair, VHR, with transversus abdominis release, TAR, and permanent synthetic mesh at Cleveland Clinic Foundation. Propensity matching was performed to create a 1:3 ratio of current smokers and never smokers and compared wound complications and all 30-day morbidity between the two groups. Results. 106 current smokers and 304 never smokers were matched. Demographics were similar between the two groups after matching, with the exception of chronic obstructive pulmonary disease, COPD 22.1% versus 13.4%, P less than 0.001, and body mass index, BMI, 31.1 versus 32.6, P equals 0.02. Rates of SSI, 12.2% versus 6.9%, P equals 0.13, SSO, 21.7% versus 13.2%, P equals 0.052, SAPI, 11.3% versus 6.3%, P equals 0.13, and reoperation, 1.9% versus 3.9%, P equals 0.53, were not significantly different between active smokers and never smokers correspondingly. One case, 0.3%, of partial mesh excision was observed in the never smokers group, P equals 1. The current smokers group exhibited a significantly higher incidence of pneumonia compared to the never smokers group, 5.7% versus 0.7%, P equals 0.005. Conclusion. Our study revealed that operating on active smokers did result in a slight increase in wound morbidity, although it did not reach statistical significance. Additionally, pulmonary complications were higher in the smoking group. Notably, we did not see any mesh infections in the smoking group during early follow-up. We believe that this data is important for shared decision-making on patients that are actively smoking contemplating elective hernia repair. When I don't see me, am I seen? Race and student perception of the surgery clerkship. Introduction. Increasing interest in general surgery from students who are underrepresented in medicine, URM, is imperative to advancing diversity, equity, and inclusion efforts. We examined medical student third-year surgery clerkship evaluations quantitatively and qualitatively to understand the experiences of URM and non-URM learners at our institution. Methods. Evaluations from 235 graduated medical students between the years of 2019 and 2021 were analyzed. T-tests were used to compare numerical data. Free text comments were qualitatively analyzed using inductive thematic analysis by 2 independent reviewers with conflicts resolved by a third. Results. Evaluations were completed by 214 non-URM students, 91.1%, and 21, 8.9%, URM students. There were no significant differences between URM and non-URM students in ratings of faculty and resident teaching. When asked whether residents were positive role models for patient care, non-URM students were more likely than URM students to agree, 3.284 versus 2.864, p equals 0.040. When asked whether they considered faculty to be positive role models, non-URM students were also more likely to answer affirmatively than URM students, 3.394 versus 2.909, p equals 0.013. Qualitative comments were similar between the two groups. When asked what the strengths of the clerkship were, the most commonly evoked theme was interactions with team, with subthemes of team integration, feeling valued, and positive faculty or resident interactions. Operative experience was the second most commonly evoked strength of the clerkship. The most common criticisms of the clerkship involved negative interactions with team, with subthemes of not prioritized above other learners and ignored. Negative academic experience was the next most commonly evoked weakness, with an affiliated theme of lack of teaching. Conclusions. URM students are less likely than non-URM students to see surgical residents and faculty as positive role models. Integrating medical students into the team, taking time to teach, and allowing students to feel valued in their roles improves the clerkship experience for trainees and can contribute to recruitment efforts. Inefficiencies of care in hub and spoke healthcare systems, a multi-state cohort study. Background. Complex surgical care is often centralized to one high-volume, hub, hospital within a system. The benefit of this centralization in common operations is unknown. Methods. Using the Healthcare Cost and Utilization Project state inpatient databases, adult general surgical patients within hospital systems in 13 states, 2016 to 2018, were identified. Risk-adjusted logistic regression estimated the odds of death or serious morbidity, DSM, and prolonged length of stay, LOS, at hubs relative to other system hospitals, spokes. Results. We identified 122,895 patients across 43 hub and spoke systems. Hubs completed 83.2% of complex and 59.6% of common operations. For complex operations, odds of DSM were significantly lower in hubs, or 0.80, 95% C, 0.65, 0.98. For common operations, odds of DSM were similar between hubs and spokes, while odds of prolonged loss were greater at hubs, or 1.19, 95% C, 1.16, 1.24. Conclusions. While hub hospitals had lower odds of DSM for complex operation, they had higher odds of prolonged length of stay for common operations. This finding shows an opportunity for improved system efficiency. Next article is from World Journal of Surgery. War Zone Pediatric Trauma Care, Lessons from Civilian Medical Staff in. Introduction. The article discusses the challenges faced by civilian healthcare providers in Kyiv, Ukraine, during the conflict in treating pediatric trauma resulting from war-related incidents. Methods. The authors share their experiences and insights from managing a series of 12 pediatric patients admitted to the Almaty Children's Hospital between February 25 and April 1, 2022. During this period, the hospital was under constant threat due to the military conflict. Results. The patients, ranging in age from 3 months to 17 years, suffered injuries from various causes, including vehicle shootings, explosions, and other traumatic events. The interventions and timely management are discussed, and 2 detailed clinical cases are presented to illustrate the complexities of treating pediatric trauma in a war zone. Conclusion. In summary, the article sheds light on the unique challenges faced by healthcare providers in a war zone when treating pediatric trauma. It underscores the importance of timely intervention, effective triage, and the utilization of advanced medical techniques to improve patient outcomes in such challenging circumstances. Scoping review, the terminology used to describe major abdominal surgical procedures. Background. Major abdominal surgery, MAS, can have a profound impact on the patient, but there is currently no consensus as to which surgical procedures constitute MAS. The main objective of this work is to ascertain the terminology used to describe MAS procedures and to apply these findings in order to propose a definition of MAS. Methods. The following databases were searched: Ovid Medline, R, All, Embase Classic and Embase, via Ovid SP, Global Health, via Ovid SP, Health Management Information Consortium, via Ovid SP, APA PsycInfo, via Ovid SP, PubMed and Web of Science. Original research articles, published between 1980 and April 26, 2022 that contained a description of MOS procedure were included in this study. Article screening and data extraction was undertaken independently by 3 authors. Content analysis was performed to identify key terminology used to describe MOS. Results: 5,663 articles were identified, of which 767 underwent full text review and 312 were included in the scoping review. Content analysis resulted in 4 main categories: 1. Preoperative factors, 2. Intraoperative factors, 3. Operation-related factors, 4. Postoperative factors. Operation-related factors was the predominant category, 1,137 references coded. The gastrointestinal resection made the vast majority of the references coded, 591. Conclusions. Based on these results, the term major abdominal surgery should be defined as an intraperitoneal operation with no primary involvement of the thorax, involving either luminal resection and/or resection of a solid organ associated with the gastrointestinal tract. However, further work is required to verify this definition using real-world data. Safety and feasibility of emergency robot-assisted transabdominal preperitoneal repair for the treatment of incarcerated inguinal hernia, a retrospective study. Background: few studies assessed robotic in emergency setting and no solid evidence was demonstrated. The aim of this study was to evaluate the feasibility and safety of robot-assisted transabdominal preperitoneal (RTAP) repair for the treatment of incarcerated inguinal hernia. Methods: we retrospectively searched from a prospectively maintained database patients who underwent RTAP or open surgery for incarcerated inguinal hernias from January 2018 to March 2023. The primary endpoint was to assess safety and feasibility of the RTAP compared to the standard approach. For eligible patients, data was extracted and analyzed using a propensity score matching (PSM). Results: 34 patients were retrieved from our database, 15 underwent RTAP, while 19 underwent open surgery. Mean age was 73.1 plus or minus 14.6 years, 30 patients, 88.2%, were male and mean BMI was 23.5 plus or minus 3.2 kg/m2. No intraoperative complication occurred. 3 cases requiring small bowel resection were all in the open surgery group, p equals 0.112. The operative time was 108 plus or minus 31 minutes versus 112 plus or minus 31 minutes in the RTAP and open surgery groups, p equals 0.716. 7 postoperative complications occurred, only 1 classified as severe was in the open surgery group. The length of hospital stay was 2.9 plus or minus 1.8 in the RTAP versus 4.2 plus or minus 2.3 minutes in the open surgery group, p equals 0.077. PSM analysis showed similar postoperative outcomes and costs in both groups. Conclusions. Despite its limitations, our study appears to endorse the safety and feasibility of the robotic-assisted treatment for incarcerated inguinal hernia. This approach yielded comparable results to open surgery, albeit in a limited number of patients, suggesting it might be a viable alternative. Thank you for listening to This Week in Surgery, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.